Welcome to today's explainer. We're jumping right into something absolutely crucial today, the high-stakes world of medical communication. We're basically turning this into an interactive training session. We're going to look at exactly how critical information gets passed from one healthcare professional to another, and, well, how getting that transfer right, or getting it wrong, can literally be a matter of life and death. We'll be exploring a standardized tool that's actively transforming hospitals worldwide, reducing errors and saving lives.
Hello.
Yeah, ma'am. Sorry to disturb you. I'm calling to inform you about a case we received in ER. 11-year-old boy. Ma'am, he's not doing very well.
Sorry, who's this?
Sorry, ma'am. I'm Dr. Yash calling from pediatric ER, ma'am.
Okay, what's happening?
Ma'am, actually, he came in the morning with abdominal pain, or maybe since last night, parents are not very sure, and he has vomited for a couple of times also. Ma'am, birth history, child was born full term, normal vaginal delivery, cried immediately after birth. Um,
Okay.
Immunizations are up to date, ma'am, as NIS schedule, and there is no history of allergies, and developmentally also child is normal.
Okay, but what's the problem now?
Yeah, so ma'am, child is having abdominal pain mostly on the right side. I think he's very uncomfortable and slight feverish is also there, and he has not eaten properly, ma'am. Vitals are slightly off. I mean, I don't have exact numbers right now.
Have you examined him?
Yeah, ma'am, I have examined. Abdomen is little tender somewhere as child is not cooperating much, ma'am.
Okay. When did the child last pass urine?
Just a minute. I'll ask the sister. Sister, when did child pass last urine? Okay, 5 years ago, ma'am.
Any investigations?
Ma'am, we sent basic investigation in the morning. I'll just ask sisters and update you.
Okay, what about the ultrasound scan?
Ma'am, we did a scan and it was showing a feature of appendicitis.
What do you want me to do?
Ma'am, we were thinking maybe appendicitis, so just thought to inform you and maybe you can come and see him.
Pause this for 2 minutes, ponder over these questions. How did you think this handover went? What could the pediatric resident have done differently? Seriously, take a moment. Think about the confusion, the missing pieces of information, and the massive potential risks to the patient you just witnessed in that flawed scenario. Keep those thoughts front and center as we move forward. Well, if you noticed some pretty serious gaps and missteps in that last interaction, you are right on the money. I am going to introduce to you a simple, structured framework that will help you organize your handovers better. It's an incredibly effective tool known as ISBAR. It's designed specifically to cut right through the chaos of a busy clinical environment, making absolutely sure that no vital detail gets left behind when transferring patient care. Okay, let's dive into this. 80%. According to a massive review of nearly 23,000 medical malpractice cases, that is the astonishing percentage of serious medical errors directly connected to caregiver miscommunication during patient handovers. I mean, to put that into perspective, that's nearly 2,000 completely avoidable deaths linked just to the way information is or isn't shared. In fact, between 25 and 40% of all adverse patient care events are caused by breakdowns in verbal and written handovers. It's a huge deal. But where did the solution to this massive problem actually come from? Interestingly enough, it didn't start in a hospital ward. It was originally developed by the U.S. Navy to guarantee clear, precise communication in the incredibly high-risk environment of nuclear submarines. Recognizing that a breakdown in communication in any high-stakes setting can be catastrophic, the healthcare sector essentially adopted this exact same structured style. Organizations like the Joint Commission realized disorganized communication was a leading cause of unexpected hospital deaths, and they brought this tool in to standardize things and ultimately save lives. Let's move to and see how this builds. Enter ISBAR. It stands for Identify, Situation, Background, Assessment, and Recommendation. These 5 distinct steps create a highly logical sequence. They actually force the sender to organize their thoughts before they even start speaking, and they let the receiving clinician anticipate the flow of information. It replaces scattered memory and panic with a solid, reliable, structured checklist. Let's see exactly how this works in a real, high-pressure clinical emergency. We're going to use the transcript from our source material to really bring this framework to life. Step 1 is identify. Hi, Dr. Ben. This is Nurse Charles calling from the ICU about Mohammed. This step ensures there's absolute clarity about who is speaking, what department they're in, who they're talking to, and exactly which patient is being discussed, often using full names and dates of birth. It sounds basic, right? But explicitly confirming identities prevents dangerous mix-ups from literally the first second of the conversation. Next up is this situation step. Notice how Nurse Charles gets straight to the immediate clinical focus. He started convulsing at 10:22 a.m., admitted with malaria and severe acute malnutrition. There's no rambling, no unnecessary detail. The situation step is all about the primary reason for the handover. What is happening right now? The doctor instantly knows this is an active, time-sensitive emergency regarding a highly vulnerable infant. Then we flow seamlessly right into the background step. Here, Nurse Charles provides the essential context. No history of convulsions, vital signs have been stable throughout the night. This gives the receiving doctor the medical history they absolutely need to understand the current crisis. By stating that the convulsions are a completely new development and summarizing the recent lab results, the sender is painting a complete and accurate picture leading up to the immediate emergency. And this brilliantly illustrates the assessment phase. The nurse relays his current, real-time observations. Blood sugar is 54, heart rate 132, no signs of cyanosis. This is where the clinician shares their objective findings and critical vital signs. It empowers the doctor on the other end of the line to evaluate the severity of the problem. So in this specific case, recognizing the severe hypoglycemia that's likely causing the child's seizures. Finally, we reach the recommendation step. A clinical handover must end with a clear, actionable request to remove any and all ambiguity. Nurse Charles asks, "We would like to administer IV glucose. Would you like to come and see the patient?" This is so crucial. It's not just passing along a list of facts, it's collaboratively defining the exact next steps. It prompts immediate decision-making and ensures both team members are on the exact same page regarding treatment before they even hang up the phone. Now, what's really interesting about this slide is that the hard data completely backs this entire process up. In a rigorous pre- and post-intervention study published in the journal Frontiers, conducted in a highly complex pediatric hematology oncology ward, no less, the incidence of nursing handover problems was at 21.57%. After training and implementing this ISBAR model, that number plummeted to 13.24%. That is a dramatic drop in potential medical errors. Furthermore, the study showed that nurses' critical thinking scores actually improved, and family members' perceptions of the handovers significantly increased because they felt more respected and informed. So, the crucial point is, ISBR isn't just a niche tool for one specific profession. It creates a universal interprofessional communication standard. It's literally designed to be used for a handover between any two team members across the entire healthcare spectrum. We're talking physicians, nurses, pharmacists, allied health workers, and specialists. By providing a clear and standardized framework, it actively reduces cognitive load during those high-pressure situations. Plus, it really helps to reduce power differences and hierarchy that might otherwise make a junior staff member hesitate to speak up and transfer critical info to a senior physician. It's definitely worth noting that ISBAR isn't the only framework out there. You might have also heard of IMIST-AMBO. Now, while IMIST-AMBO is fantastic for rapid, high-pressure pre-hospital environments, like, say, ambulance crews rushing a patient into the ER, where they have to prioritize immediate injuries and treatments, ISBAR is the gold standard for ongoing clinical and hospital settings. Why? Well, because in hospital wards, during shift changes, and during clinical escalations, you really need that slightly more detailed context that the background and assessment steps of ISBAR provide for continuous, long-term patient care. It's truly fascinating how a simple shift in communication structure can transform chaos into coordinated, life-saving care. I want you to think back to that messy, confusing scenario we talked about at the very beginning of this explainer. If 80% of severe medical errors stem from miscommunication, ask yourself, how many lives could be saved tomorrow if every single hospital adopted this universal language today? Keep those 5 clear steps: identify, situation, background, assessment, recommendation locked in your head. Now watch the same handover again and see the difference.
Hello.
Yeah, ma'am, good morning. Ma'am, I'm Dr. Yash calling from Pediatric ER. We receive a case named Manoj, 11-year-old boy with suspected acute appendicitis. Ma'am, he has a lower abdominal pain for 12 hours with 2 episodes of vomiting and low-grade fever. No significant past history, ma'am.
Okay.
On examination, he has localized tenderness in the right iliac fossa with guarding. Vitals, pulse 110, ma'am. Temperature 100.8 degree Fahrenheit. Hydration status is fair, ma'am. Ultrasound has been reported as enlarged and inflamed appendix Labs showed elevated WBC of 15,860 with 86% of neutrophils.
Okay.
Ma'am, I would like you to review him urgently for possible surgical intervention. Also, ma'am, one doubt, should we keep him Nilpar oral and start IV antibiotics in the meantime? As he has not passed urine since morning, we have admitted the child and started IV fluids.
Okay, that's very good. Keep him nilpar oral, yes. Keep him adequately hydrated.
Okay,
Give
ma'am.
him IV pain relief. Continue your antibiotics. And if you could just help me, if you could just inform your surgical colleagues, tell them to inform the anesthetist about this case and also check about theatre availability and get back to me. I
Yeah.
think I should be there in about 20 minutes' time.
Okay, done, ma'am.
Thank
Done.
you.
Thank you, ma'am.